It's an honor and my pleasure to be here today. It makes my heart full being you guys taking the time coming here. This is the big step. You guys just wanting to learn more, wanting to be informed about the disease is amazing. Thank you so much for being here. And I'm happy to answer as many questions as you have. I want to make this a little bit informal. I talk a lot with my hands, and I'm just getting over a cold, so I'm going to be sipping on some water, but just bear with me. We'll make it through, and I'm happy to answer any questions. As they say, I'm originally from Mexico, and I'm born and raised there. I did my studies in Texas, so that's where I went to school, and I did my residency in internal medicine. I moved to Alabama 4 years ago to do my fellowship in pulmonary critical care, and that's when I first started working with Dr. Barney. While I was doing my fellowship, I always said I want to go back to Texas. Like always, I had that in my mind. Things did not, pan out the way it should be, but it's for a reason. And I was offered a job working at UAB in the interstitial lung disease clinic, and then the sarcoid clinic with Dr. Barney, and that's how that's how everything fit into place. So that's how I'm doing. And I've been a good team with Dr. Barney, Lanier, and three of us run the sarcoidosis clinic at UAB. So we're going to talk a little bit about sarcoidosis. I know many of you have known about this disease, but I just got a little bit of perspective and history about sarcoidosis. So it's a systemic disease of unknown cause. It's characterized, but it's an abnormal collection of inflammatory cells. Your body starts creating or acting out, that's the way I would say, acting out, asking these cells to form these little lumps or nodules are called the granuloma. As it was mentioned by our previous speakers, this disease can affect any part of your body, but it's most commonly affects the lungs. That's why most of the pulmonologists end up treating sarcoidosis, just because it's the most common one. But I have many patients in our clinic that their lungs are perfectly fine, and we're treating all sarcoidosis other places in your body. And you cannot compartmentalize the patient. You have to see the patient as a whole. So let's just do I love history. So every time when I do a new disease, I like to know where does it come from? How did it come with this name? So it was a long time ago in the 1860s when this first gentleman first described sarcoidosis in the hands of a co-worker, and they showed these symmetric skin plaques on their hands and legs on a female. And there was raised and it had dusculations. And then this is the first description of skin sarcoidosis. This was a long time ago. They had not added the name of sarco just yet, but that was the first time when somebody discovered or described these lesions. It was not until a few years later, this is a Norwegian dermatologist, Dr. Cesar Beck. He was the first one that actually coined the term of sarcoidosis. He had a patient, was a policeman, who had these skin lesions, and he also had inflamed lymph nodes. And when he biopsied those lesions, when you look at them under the microscope, they talk that it looked like a sarcoma just because the way the cells were aligned with each other. So that's when, this is sarcoid, the sarcoid plaques. This was a long time ago. That's where the term sarcoidosis comes with it. So let's talk about who gets sarcoidosis. So this is a disease that affects people all around the world. It affects all races, both sexes and all ages. However, there is a preference in the modality. Usually it's rare, somebody less than age of 16, like in kids and so forth. And then it has been described even up to age of 60, the first diagnosis of sarcoidosis. In the United States, there's a bigger preponderance in African Americans. And I'll show you some data that we have about that. So this is a study done out in Detroit in Michigan when they look at the incidence, which means incidence are the new cases of sarcoidosis around in this area. And you see how there is a race preference among African Americans when compared with Caucasians. And it's just something one of the population studies that has been done before. When you look around the world, in Europe, there's Caucasian patients that get sarcoidosis, but here in the United States, the African American population is most commonly affected when you compare it with Caucasians. While we have not able to pinpoint what causes sarcoidosis, because we have not been able to prove it in clinical trials, there are many associations, and I do believe this is a two-hit theory, right? You have the right genetic information, and then you get that hit, that second hit. The first hit is whatever genetic material you're born with, and then there's something that makes your body react or act in a way that is abnormal. And there are studies out there when people, especially back in the day, they use a lot of wood-burning stoves, inorganic particles, insecticides, moldy environments that will create a reaction from your body. There's also occupational associations, especially in the Navy, metalworking, firefighting. So after 9/11, when we had all those firefighters cleaning the debris out there, the diagnosis of sarcoidosis skyrocketed. So I do believe there is an exposure. There's something that triggers your immune system. You need to be primed to that immune system. It's not like if all of us, well, this is a very selected population, but brothers and sisters and so forth, they live in the same place. Not everybody will get it. But if you have sarcoidosis and you look at your brothers and sisters, they're more likely to have it than if you don't, and if one of your brothers don't have it, okay? So this is a little bit of science, and bear with me, I'm going to try to make it in a way, because I think it makes a lot of relevance and why this is so hard to diagnose and hard to treat. So we talked about the person that is primed to develop this disease. For some reason, they're just primed to do it. They are exposed to either an infectious agent. There's also descriptions about certain bacterial infection and fungal infections that could potentially be the inciting event. Then some organic particles, we talk about mold, mildew, insecticides, and so forth. And then also inorganic agents, dust, debris, and so forth. That creates your T cells. Your immune system is comprised by two different cells, B cells and T cells. The B cells produce antibodies. So when you get your pneumonia shot, your B cells start making the antibody against pneumonia. It's something that is in your serum. Your T cells are a different type of cells from your immune system. What they do is you think about like a gang, like, okay, oh, that guy over there looks bad. Okay, I'm gonna get my buddies in here, get the other cells, and they form like a granuloma. That's the main issue. It's just that all the cells get recruited on a line trying to wall off the bad thing or the foreign thing or anything that you feel that is attacking your body. So that's what happens in sarcoidosis. Your T cells get activated. They're the antigen presenting cell. They tell, hey buddy, there's something out there that don't look good. So the T cells is like, oh, let's all come on because we need to wall off this abnormal thing. And that's what they do. And they form the granuloma, which also creates or produce substances that are part of our fighting system, our own body fighting system. However, trying to do that, our body not only fights the bad things or what is perceived as bad, but it also takes a toll on the rest of our body, making us feel lousy, making our lymph nodes swollen, and many other things, okay? In sarcoidosis, one of the major challenges is patients are so different. There's not a single patient that behaves the same as the other one. So there are many patients, and the vast majority, they have it and they do well. They don't, they may have symptoms for about a year, and then the disease goes into this latent process, but it doesn't happen to everybody. Why is that? We don't know. We believe that it has to do with this process of these T cells, when they recruit certain cells, they divide themselves into helper cells, the little kind of the soldiers and the commander, the soldiers. So the soldiers, the group 1 and then the group 2. And we think about when you recruit more of group 2, you tend to migrate more towards fibrosis. And when we talk about fibrosis, the lungs are the most common, but that can also happen in other parts of your body, like your liver, spleen, and so forth. The heart. Let's talk about the heart also. So this is a granuloma. This is a picture. This is a real picture of a granuloma. You will see this is it is very well circumscribed. It is very tightly packed, and this is what we call a multinuclear giant cell, which is just part of the defense mechanism from your body trying to fight off that thing that is perceived as foreign or as noxious to your body. So how do we diagnose sarcoidosis? So you probably, I think, especially my three ladies in the front, like they probably are experts, should probably come to clinic and help me see patients. You will get to clinic faster.
We can write a book.
Yeah, we should do that. So it is a numeric kind of test. This is a disease that is hard to diagnose because the symptoms are so vague. It is not uncommon when I see my patient and they're like, well, I've been seeing doctors for 3 years, and the last doctor I saw told me I need to go see the psychiatrist because I am going crazy. And many medications, they told me I had cancer. So that, what you're saying, it's unfortunate, but it's not uncommon. So it is very vague symptoms. It's especially feeling lousy, a lot of night sweats, swollen lymph nodes, especially those lymph nodes that come and go with no sense. You can get rashes, your hands, your face. I'm going to show some pictures about that. Then they'll do an X-ray, or you start having this dry cough. They do the X-ray, and somebody tells you, oh, you have cancer. And that's not true. As Alice was saying, a biopsy is indicated in most patients. You should have a biopsy because, yes, there are many, many things that could potentially be wrong. So you want to be sure that you have the right diagnosis so you can get the treatment that you need to have. And I said, other kinds of symptoms should be ruled out. Make sure there's not an infection, there's nothing else going on. Because this is a diagnosis that is not a death sentence, but you need to take it seriously so you can take action, you take the proper actions to take care of yourself. So sarcoidosis is a diagnosis of exclusion. So there's a lot of things that need to happen in order to make the diagnosis. When we see a patient in our clinic for the first time, you'll see I always send everybody to the lab to do this comprehensive blood work because we look for other things, not only infection causes, but also other type of autoimmune diseases. It's very common if you have one autoimmune disease like sarco, you can have another one. So there's a lot of overlap syndromes, patients having sarcoidosis and then having rheumatoid arthritis and so forth. So we talk about potential clinical manifestations, the lungs, skin, your eyes, your hands, especially arthritis, deformative arthritis. These are the plaques that are painful. They usually appear on the shins, skull, erythema nodosum. That is very classic for sarcoidosis. And this is hard to see here, but this is a CAT scan and shows a liver. This is the liver and this is the spleen. And then you'll see there's a little spots that are a little bit darker. Those are the granulomas infiltrating the liver and the spleen. So those are the things. And then, as I said, you get a CAT scan and then, oh, you have cancer. Until they biopsy, it's like, oh, no, it's not. It's sarcoid. So we talked about it's a multi-system organ to affect many, many, many parts, any part of your body. And when I say any part of your body, I mean any part of your body, like anywhere. The most common are the lungs. That's why they come to the pulmonologist. That's how I get my patients. But then the skin is the second one, the eyes, especially the eyes, and those are kind of hard to treat. And then the liver. But you said the lymph nodes, the nose, the throat, neurological. We've seen fair amount of patients with neurosarcoidosis in our clinic, and cardiac. And I'm so glad we have some cardiac patients here. I did not did a special cardiac sarcoid, but I could talk for 3 hours about cardiac sarcoid because that's like my area of research interest. You were totally right. Because, and the reason for that is because we've become, in the last 10 years, more sophisticated in our imaging techniques. So that's why I think always, if you look at the literature, always say, oh, cardiac is so rare, it's so rare. No, it's not rare. We just have not been looking for it. We have not been able to detect it in a prompt manner. So now we've been able to have develop this sophisticated imaging studies like cardiac MRI. When you have a pacemaker, a lot of my patients that come to me, they already have a pacemaker, so they can have a cardiac MRI. So we'll do a cardiac PET, which is different than a full body PET. It's not the same one, it's a different protocol. But that tells me if there is active inflammation, if the treatment that I'm giving my patient is working, is this getting worse? What do I need to up the ante? What do we need to do, right? Because we need to make sure the heart, that you need, although I'm a pulmonologist and I think that the lungs are the most important organ in the body, I have to give the heart some credit. Yeah, we kind of need the heart. So we have to make sure that all of them. So lupus erythematosus, which is a rash in, will usually happen in the nose, in the bridge of the nose, and in the cheeks. It's non-painful. It's very common it's more common in African Americans. But when I see a patient that has this type of rash, it's different than if the rash appears somewhere else. That tells me that this patient probably has more severe sarcoid or more difficult to treat. So I'm always going to take probably advance the therapies faster, and this patient has somebody that doesn't have it. Okay, so those are kind of the clues that me as a clinician can take.
How do you tell the difference on that between that and rosacea?
Oh, that's very good. So that's very good. Sometimes we need to do a biopsy, and especially rosacea goes away with the corticosteroid cream. This doesn't.
Okay.
So you treat it as a rosacea, but it doesn't get better. Yeah, you biopsy, and then you see the sarcoidosis. This is a disease that we need, although in many instances the pulmonologists are driving or kind of leading the effort. This is a multidisciplinary approach. We have our special dermatologists, our special cardiologists, our special rheumatologists, because it's not a one man or one woman show. We need to work as a team. If I see a rash that is like, I am not doing, this doesn't look right. I don't know what it is, but I don't look right. I phone my friendly dermatologist, hey, can you come over? Oh, let me take you a picture about this, because is this infected? Do I need to, oh, let me go down the stairs and biopsy it. So I think that's the way medicine should work in it overall. So this is just saying that this is for research purposes. So we see that the vast majority of patients with sarcoidosis around the world, okay, when they get diagnosis, they're either stage 1 or stage 2 on the lung one. You see just the lymphadenopathy, maybe a little bit of retraction in here. What it just means is just the lymph nodes that are in the lungs, they're a little bit enlarged or a little bit scarred in here. So this is the vast majority, okay? However, in Birmingham, Alabama, well, I would say in the state of Alabama, this is not true. Unfortunately, the patients that I see, many times they're on advanced stages. Last week I saw this gentleman came from Mississippi. He has had sarcoidosis for 10 years. And he broke my heart. Like, he's just like so advanced in his disease, and we're so behind on the things that we need to do that it's like, man, like I need to go to Mississippi to talk and this, that. And then, you know, physicians are there in the community. This is a disease that is very hard to treat. So if you don't know, call us, send the patient to us. We're happy, and if we don't know, we'll figure out a way to make this patient be seen somewhere that we can find what we can do for him or her. So yes, although the literature says that early stages, in my experience at UAB in Birmingham, Alabama, It's not that. So take that with a grain of salt. So now let's shift gears. We talk a little bit about what what causes sarcoidosis, who gets it, how do we diagnose it, and what are the things that you look at. So now I think where the big bucks are is how do we treat it, okay? Because that's the thing, like, well, I have it now, what do I do for it? So watching and waiting, you know, as I said, most patients with sarcoidosis do not require therapy. Say many patients with limited disease have no evidence of other organ involvement, so they just need a little bit of supportive therapy. And the vast majority will go on remissions without only supportive care. So this is what I tell my patients when they first see me, because they're scared, they don't know, so I'm not gonna tell them like this is bad. No, because there's no point. And because there's evidence out there that you play the odds, you're probably gonna do okay. But again, that is around the world. In my experience in Birmingham, Alabama, you know, we see patients that are advanced and they have other things. So we're going to talk about that. So in many instances, we do this, just watch and wait. Okay, well, you got a diagnosis, you're doing okay. Let's just do breathing tests every 3 months. Let's see you back again in a couple of months and figure out that everything is okay. But we don't know. What we don't know is there's no reliable prediction of who is going to do bad. And then if we don't treat, if you are having a little bit of symptoms, but you don't treat them, are these patients going to progress more? And we don't know that. There's no trial looking at this. So that's where we're coming. That's going to come a little bit later, what we're going to do about this, okay? So there's most of the indications for treatment. This is all come from expert opinion. People like Dr. Bob Bauman, Dr. Joseph Barney, that they just, a bunch of men got in a room thinking and figuring out who are we going to treat. So these are consensus guidelines. When your lung function is declining significantly, that's why we do serial breathing tests. When you need oxygen, when you first get diagnosed and you require oxygen, that's also a need for treatment. When there is brain involvement, when you have cardiac sarcoid, when there's severe skin involvement, and also when your calcium is elevated and may cause kidney stones, those are indications for to get treated right away. If none of these are present, the watching and waiting to a strategy is acceptable, okay? But that's why we need to keep a good eye on you. And why? Because there's limitations in clinical research on sarcoidosis. And I think Alice said very well, you know, there's limited high quality evidence with treatment options. This is not like diabetes or heart disease. When you have high quality studies looking at how medications improve quality of life or mortality and so forth. In sarcoidosis, patients are so different, so it's very hard to get those studies done. There's no agreement on outcome endpoints, because if you do pulmonary, are you going to do the eye, are you going to do the skin, etc. And then most of the recommendations come from expert opinion. So this is what's available for therapy now. So it's a lot of medications, and I'm going to talk about them and you know, how do they help us and so forth, okay? So we have some harm. This is Dr. Barney. So first of all, steroids. So who has been here in this room on corticosteroids? Who has taken steroids? I've taken steroids. Okay, all right. So why do steroids do? Why do steroids help? Why did my doctor give me steroids? So remember all the soldiers, the commander and the soldiers? So the steroids comes to tell the soldiers to stop right there. And they also stop with those substances that are secreted by the granulomas. They kind of put a hard stop on that. And also accelerates lymphoid cell death. So steroids are very good to put a brake on that acute inflammation. That's what they do. And this has been analyzed in several studies. So a Cochrane review means is somebody looks at everything that has been written, any kind of evidence on corticosteroids, and what do they look at? They improve chest x-ray, they improve the symptoms, especially the night sweats and the fatigue, improve Functional status, patients being able to do more, but there was no change on lung function. We talked about the spirometer, the breathing test, and no definite disease modification. But we still treated at the first line when you have evidence of sarcoidosis in these organs. I would say that steroids are good to put down a fire, okay? Because what's the other thing that steroids do as well? They also make you have central obesity, they make you gain a lot of weight, cataract, glaucoma, exactly, osteoporosis, your skin thins, and then you can get easy breakdowns, okay? So, although corticosteroids are the main stem of treatment, if there is a patient that's going to do treatment for sarcoidosis that's longer than 3 months, we should probably look for things that are not steroid. Because we think that sometimes steroids may suppress the inflammatory reaction that leads to fibrosis, but also it can prolong this inflammatory phase. It makes you more propense to infections and so forth. So if you're going to require treatment for longer than 3 months, then we need to think about a steroid-sparing agent. Okay? So we'll talk a little bit, I know we're probably, I don't know if we're good at time, but I can speed up on this, okay? Here we go. So we'll talk about antipyretic plaquenil. It's very commonly used for cutaneous sarcoidosis. It also helps in this dry cough, especially because the dry cough is because your airways are so dry, so that you cough, but nothing comes out. So that's help. It has been studied mostly in small clinical trials to work together with other immunosuppressive therapies. So we usually do plaquenil and something else. The only thing, the backside with plaquenil is that you need to make sure your eyes are checked every so often, once a year, because of potential retinal toxicity. Methotrexate is a very, very, very old drug. It's most widely used steroid-sparing agent. This is the one that we've used the longest, so we're very comfortable using it. It has a slow onset of action. So you start 4 pills once a week, but it takes about 3 to 6 months to see full effect. It is very hard on your stomach. It is the lousy Monday syndrome. You see, the day that you take your methotrexate, that day you're out. You feel puny, you can't tolerate it. Sometimes when patients cannot able to take the pills, then we switch to the shots. But it takes a while to get it. So it's not uncommon to get somebody on steroids to begin with, and then overlap methotrexate. And when we give some methotrexate, sometimes they start working, and then we start coming down on the prednisone, on the steroids, okay? There is reported improvement in all these areas of sarcoidosis, even the hepatic one, even the liver sarcoidosis.
So, Dr. Lara, are you saying that the methotrexate is a steroid?
No, it's a steroid-sparing agent. We use it in combination with steroids, okay? They need close monitoring. These medications have the potential to suppress your immune system, your white blood cell count, and your liver function, so we need to check it every month when we first start therapy, and after that, every 3 months. Okay. What about azathioprine and mycophenolate? And I'll talk about the brand names. I don't think I can put it in the slide, but I'll Imuran and Celcept, okay? So those medications, although have not been studied widely in sarcoidosis, they've been used in other autoimmune disease. And we use it when my patient cannot tolerate methotrexate for X or Y, then that will be my next set, azathioprine, mycophenolate. Sometimes I have to jump to infusions, and we'll talk about infusions in a minute, okay? There's little clinical trial, and as methotrexate, these two medications that require monitoring, your white blood cell count and your liver needs to be monitored frequently. So now let's talk about the anti-TNF alpha therapies. Infliximab and adalimumab, Humira and Remicade. Okay, so probably the last 10 years, there's been a lot of research in these medications. We've been using it in sarcoidosis affected joints, the eyes, the heart, and we have had successful cases there. Unfortunately, there's not a lot of big clinical trials, placebo control, looking at these cases. It's mostly case series, but The recommendation right now, which is based on expert opinion, is used as a third-line treatment in refractory cases. So in clinical practice, we're never going to start a patient on TNF alpha to begin with. And there are a couple of reasons for that. And probably the most common is because the insurance company won't pay for it. Unless you show them that you try all these things before and the patient is not. And that you're already 6 months behind. So I think your work is very important. We need to make sure that, well, why are we going to waste 6 months of my life with this? If Remicade is going to make, and do the work. But anyway, that's what we are. So that's like at the third line therapy. Infliximab Remicade is the most widely studied. It's effective in pulmonary skin. I have had patients that have had, like skin is just so hard to control. You put them on Remicade and those lesions melt away. It is fantastic. It's also been studied with fatigue because fatigue is so big in sarcoidosis. It's just so hard, and it's so hard to treat. So it's just some positive data about that, and cardiac disease. Although any of these medications, especially the Remicade because it's an infusion, is many centers, especially some of our cardiologists, have been hesitant to use it in cardiac disease because that can make you become a heart failure exacerbation. We've been able to use successfully in patients who have a preserved heart function and have active cardiac disease, and it helps a lot. So I do think we try it. And we try it, and I say this is just, all this stuff is like Joseph Barney, he's just so, he's bright, like, oh, let's do it. Well, no, let's just do it. And we've been successful. He's very smart. The problem with this therapy is, you have, as with any other immunomodulative therapy, increased risk of tuberculosis and fungal infections. With Remicade, it has happened that my patient starts taking it, and a year into the medication, it stops working. Or it doesn't work as good, like I can feel it. And it's because your body kind of creates antibodies for it, and it's just harder. And then what we do, we switch it to something else, or we go back to methotrexate, and so forth. So we have so much work to do in this case. There are other anti-TNF therapies that are currently evaluated, Symphony and Lara, which are being used in other autoimmune diseases like Crohn's, rheumatoid arthritis, and so forth. The data here is not as robust. So Remicade and Humira is probably the most widely used, and the ones we have more positive data. The downside of treatments, opportunistic infections. You talk about urinary tract infections, fungal infection, thrush, and also with DMARDs. It's risk of hepatic toxicity, cirrhosis, and then your blood counts can also go down. So that's why we need to keep an eye on your counts. So don't think I'm crazy when I say, okay, that's fine, we'll get you methotrexate, but you need to go get blood work once a month, and you need to fax the results to me. And like, people are like, what? Just because it's medication. So, think it's like when you have, especially when you're very high dose of steroids, can make depression and fatigue worse. Patients can just feel lousy with low quality of life, and then chronic pain. And that is something very real and very tangible and very hard to treat. Because patients with Sarcoidosis usually or sometimes get small fiber neuropathy, would give them pain, and that pain doesn't respond to immunosuppressive therapy. Pain medications also don't do a whole lot. So this is very, very hard to treat. And also, there are some case reports with patients using TNF alpha inhibitors, like Remicade and Humira, that they get worse granulomatous disease. So we have some patients that do that. So I would just say it's not one size fits all. So you have to have the perfect match for you. What is the treatment that's going to affect? If for me, methotrexate work, maybe it won't work for you. Maybe you have to try something else. But we got to try, and we have this. Expert opinion that we go by. So what kind of comprehensive care does a patient with sarcoidosis need to have? So we came up with this comprehensive care, this multidisciplinary sarcoid clinic, which has several components. First of all, you need to have at least twice a year visit to see your sarcoid specialist, because we do a comprehensive assessment, making sure that everything is okay. You may need more than that, but at least twice a year. And you can and where we can do, especially patients that come from out of state or that come from a long time from Birmingham, we coordinate with their local physicians. So they go to them every 3 months there, and then 6 months with us. So they've been seen by somebody. They need to, on every visit, they need to have a fatigue assessment score. And it's not because there's a number that triggers, but if things are getting worse, maybe it's time to change immunosuppression or do something different. They need to have at least a yearly pulmonary function test. And this can be more frequent than that, but at least every year. A 6-minute walk test. An EKG. Every patient with sarcoidosis needs to have an EKG every year, because cardiac sarcoid is underdiagnosed because we're not being so vigilant. So that's what we're doing. And if the EKG, there's something wrong, or if you're having any symptoms, then we'll jump to cardiac PET. Sometimes we'll do an echo, but we are we developed this protocol that we jump to cardiac PET easily. And we're able to detect changes early before we are in a situation where the damage is already irreversible. They also have to have ophthalmology evaluation, your eye doctor at least once a year. So now, I don't know if anybody has gone to UAB recently, but now we have these sheets that we give when you check in on the door, and they'll give you to fill out while you're waiting, because you're there for 4 hours. I'm sorry, but it is. So we have to do things like we ask these questions. Since your last visit, what has happened to you? Like, I've been hospitalized, I've been doing this, I've been having worsening night sweats. And then why are you taking sarcoidosis? And this is not because we cannot keep trying. It's because it gives the power back to the patient. You need to be in charge of your patient. You need to know what you're taking for your sarcoid, how often, what are the side effects of the medication, right? Because this is those days when the doctor said was a mantra and you follow it blindly. Those days are gone. Okay, this is a two-way street. So I give recommendations, you tell me, yes, we'll do this, we'll do that, etc. So this is part of that process. And then also, are you having any issues with your medications? Methotrexate is making me sick. Do write it down. Have you been given oxygen? Your vaccines, are you up to date in your vaccines? And then when was the last time you had a doctor? And this is very important. Who are your doctors out there? Who is your primary care doctor? Who is the one that you call when you get the crud? Who is the one that you call because something, and you cannot make it to Birmingham? And you need to know. And that way, we want to make sure that every time you come to see us in Birmingham, we give our report back to your primary physician, because they are the ones that are going to be taking care of you if something happens in a web and you need to be seen by somebody like right there. And this is a snapshot of the fatigue assessment score, and we try to get one done in every clinic, because fatigue is so prevalent. And actually, Lara and myself, we want to apply for a grant to do a study on fatigue. So that's probably, we're planning on doing it in September. The ATS Foundation has a grant with Mallinckrodt, so that's our plan in the future. So now, I want to get a little bit of time, but just like what's in the horizon. So first of all, there are new upcoming trials that we're opening. There's one of the trials is a Novartis-sponsored trial. This is an anti-IL-1. Kinase Kimub. It is Ilus. That's the brand name. It's a medication that is FDA approved. It's already being used in treatment with juvenile rheumatoid arthritis. This is a placebo-controlled trial. It is blinded for the investigators, which means I don't know what you're getting. You're getting the real drug or the placebo. And it's designed for patients who have active sarcoid with lung involvement. We're going to have our site initiation visit in 2 weeks, and we're probably going to be ready to enroll by the end of July. Okay, so we're going to be asking you guys, or whoever goes to UAB for sarcoid. I know many of you don't go there, but if you think you would like to participate in clinical trials, please let us know, and we'll have you on a database. So when their clinical trial comes up, that you are.
Will it be listed on clinicaltrial.org?
Yes, it is. This is listed on clinicaltrial.org. And you know, I could,
information is on your purple card. Check to see what the trial.
and you know, because this is a pharmaceutical company sponsored trial, I cannot put more information like about the trial because we have not started enrolling. But yes, though this trial is in clinicaltrials.gov. This is another clinical trial that we're just starting. This is Dr. Bob Bachman out in Cincinnati. Is the registry for advanced sarcoidosis is started to determine the clinical course of how patients that have only ocular do, how patients that have only lung disease do, and so forth. This is a investigative process. So this is not being sponsored by a pharmaceutical company. This is done by an investigator, and we're going to collect blood to analyze DNA on patients with sarcoidosis, and this will give us tons of information. And what Alice said is just so like this may be something that you may not benefit like directly, but it will be a legacy for people that being able to identify who are our high-risk patients, who needs prompt attention on this. It will be just a long way to go. So with that, I want to finish up my talk talking about patient-centered outcomes research, because what's important, what I do take as an endpoint in a clinical trial, making sure I'm giving you a medication and then I measure your lung capacity every 3 months. You know, oh yeah, the medication works because your lung capacity went up. But then I talk to my patient and say, you know, this medication makes me feel lousy. I'm still tired. I don't care what my lung capacity is. I want to be able to go out and grocery shopping. I want to be able to go play with my kids, my grandkids. Those are patient-centered outcomes. So what are the outcomes that actually matter to a patient? Because patients don't care. I don't care if my liver enzymes are like 5 or 50, you know, if I don't feel well, right? What does matter to me? What's a big deal? So the NIH has come up now with this PCORI, which is the patient-centered outcomes research. So there is a big push for all our clinical trials. One of our endpoints needs to be patient-centered outcomes. I want this cough to go away, right? That's what I want. I don't want my lung function. I want the cough to go away. So that's what we need to do. That's our gearing towards. But yes, we look at the other molecular organisms, we look at the chemistry, we look at all those things. But we cannot leave this behind because this is what impacts patients. This is what impacts your life. So we're just gonna wrap it up at conclusions. You know, it's a multi-system. Sarcoid is a multi-system disease of non-etiology. We have a granuloma. Clinical manifestations are very wide and variety. The most common organ that is affected is the lungs and can cause granulomas that can progress to fibrosis of the lungs. It's a diagnosis of exclusion, and many times, I would say 100% of the times, you need a biopsy to make the diagnosis. The decision to treat is controversial. However, we have some accepted guidelines on who do we need to treat. The mainstay is still steroids and in other immunomodulatory drugs, including the anti-TNF alpha therapies. And then further research that includes patient-centered outcomes is needed to assist clinicians like myself to manage you every day. And with that, I want to thank you, and I'd be happy to answer any questions you all may have. Don't be shy.
So when you said that one of the things that may be an external influence to kick off sarcoidosis, or what you call like cider, is being in the U.S. Navy, which I was.
Yeah.
Can you be more specific about the U.S. Navy?
So it's probably something you were exposed, you were deployed, something that you breathe. We have not, it's not like, well, it's a dust here, it's an Iraq, it was white in the desert, but it has been, and this has been public, the VA has looked at that. They look at patients that have been, looking at all the different branches. We see that in the Navy, they have a higher risk of that. And that plays a big role when you're a service connector or not.
Probably because a lot of times they're inside a ship, or inside a submarine or something like that.
There's definitely some kind of environmental exposure. Exactly.
Well, I can say for my case, you know, when you get something like this, you think about what happened to me in the past that might have caused this, especially since it's unknown. But I think about when I was in the Navy, for 3 years there, 2 years there, I worked in the aviation area on helicopters, and we did everything with trichloroethylene, which is also known as TCL. This is back in the 70s. Not long after I left the Navy, they outlawed TCL as a solvent.
Exactly.
So I wonder.
Yes, and that might have been your trigger. We have not, the problem is we have not been able to prove it. But I do believe that definitely, that's why we'll get it. Why you get it, I don't get it. It's just because you were exposed to something and you just have the prime genetic material for that.
If it was the trigger, it was 40 years before I was diagnosed.
Exactly.
So I don't know. I mean, that's a little bit long
And
time.
probably that was a trigger.
I worked for NASA, and the building that I worked in is a 1950s, 60s building with asbestos, and 3 people in that building, and there aren't that many people that work in the building I was in, were diagnosed with sarcoidosis.
When he's been taking prednisone for so long, it caused osteoporosis, which causes fractures, which causes you to have to take pain medication, which causes other problems. So how do you break that cycle?
So it is hard. I'm saying it's hard. The first thing that I would do is try to come to the lowest dose possible.
Well,
5 milligrams.
Okay, so that's pretty manageable.
but anytime there's a real problem, though, the doctors amp it up for a few weeks, and then that causes problems.
So then we need to look into other therapies, like Actar, which is a, and it's not like I'm prescribing. I'm just thinking when I have a patient that is hard to get off prednisone, then I have to think about, okay, prednisone is doing something, so what am I going to use to substitute prednisone? So you cannot take prednisone unless you put something that's going to do what prednisone is doing. So that's the way we approach it, maybe something different. And then now we have this new medication called Actar, which is a precursor of cortisol that you get infused, you get shots for that. It's very expensive, it's so hard to get it approved and all that stuff, but it does work. In the ideal patient, somebody that is very hard to get off prednisone, that's something that could be tried.
So how long is so long? You said you've been taking steroids for so long.
How long have you been taking prednisone? 4 years, 5 years?
Wow. I've
That's
been
a
taking
program.
10 myself. At 10 milligrams.
Wow.
Yeah.
Did you get osteoporosis?
I don't know. I don't think so. I think we did a bone densing not that long ago, and I think it was okay. I mean, it wasn't like great, but it was okay.
And also, it's very important that if you are taking prednisone for a long period of time, you need to have all those bone densities. If you have osteoporosis, you probably should be treated for that. And the best thing is coming off prednisone. What I do also, the hardest part when you've been on steroids for so long is when you're on that 5-6 milligrams a day. Coming off on that is the hardest. So I do tell my patients, let's just go down by 1 milligram every 2 or 3 weeks. So take 4 milligrams for 2 or 3 weeks. Okay, if you're doing okay, then go to 3. And then again, it's just tricking your body. When you've been taking prednisone for so long period of time, your body stops producing it. So if you stop taking it from one day to another, you're gonna feel real bad. So you gotta trick your body into kind of to jumpstart it to start making cortisol again. And if you go down but it has to be very, very
Incremental.
longer periods of time.
He tried that. They tried reducing his, and
Every time I tried it, it seemed like I got worse.
Yeah.
Yeah.
Sometimes it may not work in everybody, but
this new drug
Mhm.
that you said that's going to clinical.
uh-huh.
So if so you said you don't know if there'll be placebo or.
No, it's blinded.
The trial. Yeah.
So you would know right off the bat.
Well, I'd never, well, if you were replacing the prednisone with it, I'd never run off that.
Do you go to
Most
that
likely.
party?
Sorry?
Do you go
Yes,
to that
I
party?
did.
I have a question. Do
y'all have at your clinic, at your research clinic, the cardiac PET that is the newer cardiac
Yes,
PET
we
that
do
is
have.
not as damaging to your body?
We do have that.
Okay. I need to talk to you.
Yeah, so we do have it. There's actually have a patient that she needs a cardiac MRI, a PET, but they won't do it. She's from Huntsville. But I had to do all these like letters because they won't pay for it. And she's like, well, they'll pay for it if I have it done in Huntsville, but they won't pay for me. Like, yeah, but Huntsville doesn't have the same machine. And then if you're gonna just get radiated, and it won't give me the information that I need. So it's a battle. So Barney spends a lot of his time writing letters for insurance companies.
They call an insurance
I'm
company.
fighting for.
Yeah, right.
It is.
So I have a hypothetical.
Mhm.
You know, everybody, you get something like this and you do a lot of reading, you almost daily to find out, to research different things you thought of. But and I've read a lot lately about how immunotherapy is addressing cancer. It's been very successful. It's amazing what they're doing with cancer these days in reprogramming those T cells to go after the cancer cells, because somehow cancer has been able to fool the body's immune system into avoiding being detected, or I guess whatever being consumed by the body's own immune system. They basically played hide and seek with the immune system, and now they're finding ways to actually take the mask off, and so that the T cells can find the cancer cells and do something about it. And that's great. That's great news. But it makes me wonder. It seems like to me the first thing immunotherapy should be looking at is how they address autoimmune diseases, because you're talking immunotherapy. So how can we? And I guess all autoimmune diseases are essentially the same basic principle, right?
Yeah. Go ahead.
So I'm thinking that since sarcoidosis is an autoimmune disease like so many, and autoimmune diseases are gotten so prevalent these days, why isn't immunotherapy not looking at how to reprogramming those T cells so they don't attack healthy tissue?
Yeah.
So it's a twist on what they're doing with cancer now, but it's something that seems logical to me.
Yeah, I agree with that. I think in theory, yes, that would be the best way,
Yeah.
And that's the way cancer treatment has revolutionized now. Now we're able to know cancer to the molecular level. You're able to give somebody that has a very aggressive cancer a pill, and that pill will take care of it without having to do the toxic stuff that we did in the past. The problem, I think, the major barrier to get that fast up in sarcoid is because patients are so different, and we have not been able to identify one receptor or one molecule. They're all usually like 5, 10 different, and you need those to do that. I just I know we're out of time, but I just wanna hear, because they're like interleukin 1, 2, gamma, interleukin 4, 5, 6, 10. So they're all this TNF alpha, interleukin 12. So there are a bunch of receptors and a bunch of substances that interfere, or they are in the whole process. So you can't block them all because you need them for your other disease process. So it's just a little uncomfortable, but yes, ideally that would be the way. It's like, yes, you have sarcoid, but what's wrong with you is an interleukin 4. So I'm gonna give you this pill, and the only thing that does is this, and then you're gonna be fine. That would be. Hopefully one day we'll get it.
Hopefully one day, yes. That's what I hope for.
I have sarcoidosis. My baby girl has lupus, and my oldest daughter has leukemia. Is all that coming from me?
It's not coming. It's not just coming from you. No, no. It's not like you're the. But definitely, when you have an autoimmune disease, it's most likely that your siblings or your offspring can have it. Okay. So when I see patients, I ask them, okay, anybody else in your family with sarcoid? Well, now that I know, what about rheumatoid? Oh yes, my mom has rheumatoid. Like, oh, okay, well that makes sense. That also rings a bell in me saying that, well, she may have sarcoid and overlap, sarcoid and rheumatoid. So, yes.
Just not now.